Right. Well, hi everyone, and thanks very much for giving me the opportunity to discuss our latest paper, which is our interim results from our UK CLL study looking at antibody responses to the first and in a proportion the second vaccines of the Pfizer and Oxford AstraZeneca vaccine. So just a little bit of an overview of how we've run the study. So recruitment has concluded now, and we now have 550 participants that have consented and taken part. Of those, there's a good split between the two different vaccine types. So 319 have had the Oxford AstraZeneca and 224 have had the Pfizer biotech vaccine. And then we've asked participants to either provide a dry blood spot test, which they do in their own home. So we send the kit in the post. And that is really for participants that are taking part that live outside of the West Midlands. And from that, we can get the antibody level results to COVID and also total serum immunoglobulin levels. And then the alternative sample that we asked patients to, or participants to give us was a full bleed of 50 mils. And for those participants that were being bled, they were local to us within the West Midlands. And from that, we were then able to do serology, which is antibody testing again, using a slightly different method called the Roche method, or cellular work and neutralization, which is coming through at the moment, the results of that. For the dry blood spot assay, we actually used a slightly different assay that was made by the Binding Site in collaboration with the University of Birmingham. And we've shown before that there's very good correlation between the Roche assay and the Binding Site assay with the results that we get back from both assays. So if anybody's been taking part, they'll also know that we've collected quite a lot of data. So each participant we sort of spoke to for 10-15 minutes on the phone and grasped different elements of their clinical history in terms of when they were diagnosed with CLL, if they'd been treated, what number of lines of therapy they had what types of treatment they'd had, and then importantly, quite a lot of information about the infection history. So whether they'd had shingles in the past, whether they were somebody who tended to get recurrent infections, or hospitalized with infections ever, and also whether they were taking prophylactic antibiotics or immunoglobulin therapy. And because we're interested obviously in vaccine responses, we also asked participants whether they'd had the flu jab or pneumococcal vaccine history. And then just to sort of put it into a bit of context and get a bit more of sort of the behavioural side, we asked patients whether they'd been shielding or whether they'd sort of been going out supermarket shopping, and if they had known whether they'd had a natural infection with COVID. So total samples collected so far, we've now got 498 results following the second vaccine that are being analysed currently, and 110 blood samples following the second vaccine for our cellular and neutralisation assays that I mentioned. And then we've also got some control samples from our local local healthy donor population of 130. So we should get a good idea, and these are age matched between the responses to the different vaccines, if you've got CLL or if you haven't got CLL. So the interim analysis so far looked at 286 participants that were on an extended interval between the vaccines. And what I mean by that is when the rollout first initiated, everybody was planned for a 3 to 5 week interval. And then that gradually got extended to up to 12 weeks between the first and second vaccine. So as a result, we've got the majority of participants on an extended vaccine interval. So 286 so far have been analysed, of which 267 had a sample available after the first vaccine, and that was taken 5 to 6 weeks after the first vaccine. We then have 13 participants that had the vaccine slightly closer together on a 3-week interval. And overall, we've got 55 results from either those that are on the 3-week interval or the extended interval that have had the second vaccine analysed to date. And I'm just going to go on and discuss the results so far of those participants. So the demographics of that cohort that I just mentioned, the age range is 43 to 96 with a median of 69, so as you might expect for participants with CLL. And the male to female ratio is 53 to 47%. The average time since diagnosis is 6.5 years. And of those, 61% were on watch and weight management and had never received any treatment. 39% had been treated or were about to start treatment, And of those, 20% were on a BTKI, so either ibrutinib or acalabrutinib. 2% were on venetoclax, so the BCL2 inhibitor, and 24% had received previous chemoimmunotherapy. 2.7% were starting treatment imminently, and then 5.7% were on immunoglobulin replacement therapy. So the response to the first vaccination, we have found, and others have also reported, it is reduced in patients with CLL. So if we look at the top, this is looking at the Roche assay, which was performed in Porton Down for us at Public Health England. And this found that the response rate was 34% in participants with CLL compared to 94% in our healthy donor control population. And also the magnitude of the response was also reduced. So you can see on the graph on the right-hand side here that those who have CLL have overall a median lower magnitude of response, antibody response, compared to that of healthy donor controls. Interestingly, we found that those who had natural infection, which can be seen here by the red dots on the Roche graph labeled B, that actually the vaccine, even in amongst the CLL patients, boosted the immune response 24,000-fold, so really incremented that response. And I think that's quite encouraging, because that does really suggest that priming for a vaccine response does still work in patients with CLL. Only 2 out of the 5 of those participants actually were aware that they'd ever been infected with COVID. So there were 3 out of the 5 that weren't even aware that they'd had COVID. You can see underneath now in figure C and D that the DBS assay mirrors quite nicely the Roche assay, but obviously the numbers are far greater here. And we see the same difference in terms of the percentage that were able to respond to the vaccine, and also the magnitude of that response is lower amongst patients with CLL. So we then went on to have a look at the disease management type and how the vaccine responses altered with depending on what management stage patients were at. And really, already we're starting to see, after just a single vaccine, that participants on a Bruton tyrosine kinase inhibitor, BTKI, were less likely to respond to that first vaccine compared to those on watch and wait. And we were also starting to see that those that had previous chemoimmunotherapy were having quite good responses. So when we looked at the different vaccine types, we haven't so far found any difference between the AstraZeneca and the Pfizer vaccine in terms of the response, the antibody response so far. Remember, this data so far is just looking at the response to the first vaccine. So we then looked in 55 participants at what the response to the second vaccine was. And here we showed that 75% of CLL patients showed a response compared to 100% in healthy donors. So there's quite a marked improvement in terms of the responsive rate in patients with CLL after that second vaccine. But again, that magnitude of response was 74-fold lower than healthy donor controls. So they're not able to mount the same magnitude of antibody response as we see in healthy donors. So again, smaller numbers here because it's 55, but we looked at what was influencing that response to the second vaccine. And again, the participants that were taking Bruton tyrosine kinase inhibitors were significantly shown to have reduced responses compared to those that were on watch and wait. And actually that carried forward when we looked at the odds ratio, and when we put that and immunoglobulin levels into bivariate analysis, they both independently predicted for poor response, so low immunoglobulin level and the presence of being on a Bruton tyrosine kinase inhibitor. Participants that have been previously treated with chemoimmunotherapy, they are few in number here, but they're in the middle there. So that PCI stands for previous chemoimmunotherapy. They were showing quite good responses, which is encouraging, and we'll look forward to seeing more, hopefully, of that data going forward when we analyse the full data set. There aren't any participants currently in this data set that have been on venetoclax or BCL2 inhibitor that have had both vaccines, but obviously within our bigger cohort going forward, we will be including a subgroup of patients on BCL2 inhibitors within the full analysis. So when we looked at the paired responses this is using the dry blood spot analysis now, and the assay produced by the binding site, if you compare healthy donors to CLLs, so to patients with CLL, you can see that there's actually a similar fold change measured between the first and second vaccine response in healthy donors and patients with CLL. But obviously with our cohort of patients with CLL, they start at a lower magnitude of response. But again, I think this could suggest that perhaps given a second booster, we may be able to potentiate that further, that antibody response. And that's certainly something that I hope going forward into the autumn may become available for participants, for patients with CLL. So as I've already alluded to, if you look at the total immunoglobulin levels, we look at total IgA, total IgG, and total IgM, and all of them show the association with a lower level of immunoglobulin correlating with a poorer response to the vaccines. So just a little infographic to show you an overview really of what our results so far have shown in those 55 patients that have had both vaccines. And you can see the vast majority of participants that are in blue are on watch and wait and have had a good response. There are some participants that have got evidence of low immunoglobulin levels that are still able to mount an antibody response. And most of the patients that have had previous chemoimmunotherapy have so far also shown a good response. What we're not seeing such great responses are in patients that are on Bruton tyrosine kinase inhibitor therapy. And also there were 2 patients that were planned for treatment who also unfortunately didn't show a great response. So a few discussion points so far. So we seem to be seeing higher response rates compared to published work that's out so far. And 83% of our participants that were on watch and wait, we were actually able to detect an antibody response to following the second vaccine. So why that is, it isn't quite clear yet. And I think obviously we will need bigger numbers going forward as we analyse the whole cohort. But it could potentially be to do with the slightly extended interval that participants have had between the first and second vaccine, because we recently published to show that in healthy donors that actually extending the interval does push your antibody levels up by around 3.5-fold compared to if you get the vaccines 3 weeks apart. But then a balance is needed, because if you get the vaccines, obviously extending the interval between the vaccines leaves a longer period of window where you are only getting immunity following a single vaccine. So there probably is a balance to be had there. The vaccine types, I don't think this is likely to be influencing it, as the majority of patients so far that we've analysed in those 55 had actually received the Pfizer vaccine, and all the other data that's published so far is in patients that have had the mRNA vaccine, the Pfizer mRNA vaccine as well. I think the natural infection data is really encouraging. I think really it hasn't been shown in participants with CLL, as far as I'm aware, that they can have such good responses, and they were equal to that of healthy donors, those that have been natural infected and then had a single vaccine. And I think that does sort of suggest that maybe if we get the opportunity to give a third vaccine, that may improve antibody titers further for patients. So what does a detectable antibody response actually mean? I get asked this an awful lot at the moment. Well, actually, we don't know what the immune correlate of protection is currently, and that is whether you have CLL or not. So even amongst the general public, it's not clear exactly what the cutoff level is that provides definite protection against COVID in terms of the antibody level. The magnitude of the response to the second vaccine, I would say from what we've seen so far, does appear similar to our healthy controls after a single vaccine. And perhaps if we look at real world data to try and sort of tease out what that might mean, well, Public Health England and Scotland showed that actually there was up to an 80% efficacy given after a single vaccination against serious infection and hospitalization. So that perhaps could be encouraging to us. But it may be different for patients with CLL. We know that the immune system is and the way that CLL interacts with it is very much more complex, and there are other factors at play here as well. And I think going forward, the neutralization data will help with that. So what I mean by that is that we actually take blood and the serum from participants that have been vaccinated and have hopefully antibodies in that serum and put it against live virus in the lab. And that's quite a good surrogate. It's probably the best surrogate that we've got for knowing how in a laboratory setting participants are going to handle the virus if they come across it in the real world. And obviously there will be clinical data going forward, and admission rates such to hospital, and infection rates will be monitored for participants and for patients, in general within the NHS. I think waning could be problematic because we're starting at a lower antibody titer. So we know whenever somebody gets an infection or a vaccine, the peak antibody response soon follows, and then it always drops off, whether you've got CLL or not. And I guess the thing here, we know with our participants that they're starting at a lower antibody level, so that magnitude, as we've talked about, is lower to begin with. So that could be problematic, because obviously if that drops off at the same rate as we're anticipating, then what that level of protection is could sort of fall below that quite quickly. So other discussion points, the suboptimal responses in patients about to start treatment needs a bit of consideration, I think. I definitely think we should still be giving vaccines before starting treatment, but it may be that these are a particular group of patients, along with those that are on the BTK inhibitor, that we really need to keep a close eye on and perhaps look at how we manage things differently here. Potentially there may be a role for the monoclonal antibodies. So there's AstraZeneca have got such a combination of two monoclonal antibodies that have been modified, so they have a longer half-life, so you inject them and they can last up to 6 to 12 months. But the trial data for that is still awaited, so we're not clear exactly what the efficacy of that drug yet is, and I think that's eagerly awaited. The other thing is protection through herd immunity. We're now up to 75% of the adult population in the UK that have had at least one vaccine, and obviously a good proportion have had the second, and going forward that will be the whole population will be vaccinated, double vaccinated, and provide herd immunity and protection to vulnerable participants and patients who can't mount immune responses. And then the other thing is repeat vaccination following therapy may be something to highlight, particularly in those that are on a finite, so such as venetoclax and obinutuzumab, perhaps, where they're on it just for 12 months. So the other thing I really would stress is that how important it is for household members to be vaccinated. Again, that goes back to sort of, protecting vulnerable patients and making sure that we're doing everything we can to minimize the chances of them catching COVID in the first place. And then, as I said, cellular studies are awaited, and these may differ from the antibody responses. So we know that certainly in different treatment types, T-cell responses, the cellular responses can be quite different to the antibody responses. So I think that really is a thing that we need to keep an eye on, and we should have that data soon in the next couple of months, hopefully. And also, as I've mentioned before, between the different vaccine types, because the different vaccine platforms can actually stimulate different parts of your immune systems differently. So that might also play a role going forward. And I think bigger questions that are still to be answered, which hopefully this data, because we've collected more information than just sort of about COVID, is, are responses to COVID vaccines likely to be similar amongst other vaccines? So that's also something that's sort of on my radar, and going forward I'll be looking at, hopefully. So I think overall we can be encouraged that the majority of participants do seem to be having a detectable antibody response, albeit lower perhaps than our healthy controls. And I think hopefully this does suggest that some immunity would be there should they, going forward, come into contact with COVID. But obviously, as I've already pointed out, the immune correlate of protection really isn't clear yet. And I do still think that people need to be cautious and careful and take precautions, as I'm sure people are, in terms of, avoiding people that have got infective symptoms, wearing a mask, and being careful when they're going out and about. I think along with that, it's really important, as I've already said, that household members are vaccinated to reduce the chances of transmission within the household. And the other thing I keep getting asked is whether people should be going out and getting an antibody test. And at the moment, I would say we don't know what that immune level of correlate of protection is. So I wouldn't be advising people to be going out to get their antibody levels checked, because how we interpret that really isn't clear at the moment. So obviously very grateful, and thank you so much to all the patients who have taken part, and also our local primary care networks for the healthy donors who willingly took part as well. Thank you to all the charities who have helped us to recruit. We're very grateful, and the response has been phenomenal. And then obviously the University of Birmingham, Public Health England for helping us with the Roche antibody testing, the University Hospital of Birmingham, and then the UK Corona Immunology Consortium, National Course Studies for Immunology, NIHR and the UKRI. Thank you.